So we are starting emergency surgery. So it's V1, very important high yield topic, acute mesenteric ischemia. A 60-year-old female with new onset atrial fibrillation develops acute abdominal pain. Your foundation doctor FY2 informed you that her abdomen is soft and due to new ECG changes, he is referring her to medical team for further management. What would you do anything different? Yes, I am quite concerned here about his acute mesenteric ischemia due to atrial fibrillation and cardiac emboli, and I will assess the patient personally. The patient typically present with spare abdominal pain, which is out of proportion with the clinical exam, often resistant to opioid analgesia and absent peritoneal signs. Assess history for embolic sources like recent myocardial infarction, cerebrovascular accident, cardiac arrhythmia, and peripheral vascular disease. Okay, so what are the causes of mesenteric ischemia? So these are divided into two, occlusive and non-occlusive. Let's discuss occlusive first. So first one is acute arterial emboli, which is 50% of the cases, and then arterial thrombosis 20%, and then mesenteric venous thrombosis 10%. So venous thrombosis occur in those patients who are deficient in protein C, protein S, antithrombin 3, and factor 5 Leiden. And secondary mesenteric venous thrombosis can happen due to portal hypertension, due to pancreatitis, trauma, oral contraceptive pill. And the other one, non-occlusive mesenteric ischemia happens, it's called 20% results from low flow state, for example, severe vasoconstriction due to the reduced cardiac output or shock, cardiogenic, volumic shock, inotropes, and ergots medication. How will you manage the patient if you suspect mesenteric ischemia? So first of all, we will resuscitate the patient with oxygen, IV fluids, analgesia, antibiotics, keep nail by mouth until the diagnosis is established. And investigation, we will do the full blood count, UNEs, coagulation profile, renal profile, liver function test, arterial blood gases, serum amylase, lipase, and serum lactate. And we will do blood culture, and then we will organize the contrast enhanced CT scan of the abdomen and the pelvis. And then I expect raised white cell count, raised amylase, lactate, metabolic acidosis, and pointing toward the diagnosis. Although these can be the late findings. Plain abdominal X-ray is rarely helpful, but it can show thumb printing sign for the ischemic colitis. If patient is septic, start antibiotic. If patient is not peritoneal, diagnosis uncertain, obtain a CT to establish the presence of any surgical pathology. Look for mesenteric. So what we will see on the CT, mesenteric gas, pneumatosis intestinalis, very important word. Pneumatosis intestinalis and fat shunt included mesenteric branches. If the patient is peritonetic, it is acceptable to forget the CT and go for diagnostic laparotomy. Elderly patients with multiple comorbidities are unlikely to survive an extensive bowel resection. Overall mortality is 90%. So have a frank discussion with the family and the patient about two possibilities: surgery, which may be non-curative, which may be non-survivable, or not be curative, and keeping the patient comfortable non-operatively. Okay, let's think you decide to take the patient to theatre. What will you do at laparotomy? So patient will be general anesthesia, supine, nasogastric tube, Foley's catheter, antibiotics, standard sterile prep, and I will do a midline laparotomy from xiphi to pubis. What you will do? So I will run the bowel from stomach to the rectum, establish the diagnosis, and assess the viability of the viscera. And then I will delineate the extent of intestinal resection. Again, another thing, a very good buzzword: delineate the extent of intestinal resection. And that may be required. Inspect patency of the mesenteric vessel, in particular the superior mesenteric artery. So how you will assess? Lift the transverse colon with the mesocolon anteriorly and palpate the root of the small mesentery for the SMA pulsation. And embolus usually lodges distal to the origin of the middle colic and inferior pancreatico-duodenal branches of SMA, sparing the stomach, duodenum, and proximal jejunum. And SMA thrombosis usually occurs at the origin. So emboli is distal, but thrombosis is at the origin due to the overflow aortic atherosclerotic disease, and only the stomach and duodenum are spared due to perfusion from the celiac axis. If bowel resection is to be performed, SMA embolectomy should be undertaken. because it will minimize the progress of bowel necrosis, ensure healing of the intestinal osmosis, reduce the risk of anastomotic diastasis and leak. Successful reperfusion will release free radicals that may cause an inflammatory response. This lead to the multi-organ system. So first we have to do the bowel resection, and then we should do revascularization. In case of extensive intestinal necrosis, the abdomen is closed without resection, revascularization, and the patient is palliated on the ward. Okay, so again let's repeat what you will do in the laparotomy. Run through the bowel from the stomach to the rectum, then then establish the diagnosis and assess the viability of the viscera, delineate the extent of the intestinal resection, inspect the patency of mesenteric vessels by flipping the transverse colon of the mesocolon up at the root of the small bowel mesentery. Embolus is usually distal to the origin of middle colic artery and inferior pancreatic duodenal artery, and SMA thrombosis happen at the origin. If bowel dissection is to be performed, do SMA embolectomy. But before embolectomy, you should do the bowel resection due to the free radicals reperfusion injury. In case of extensive intestinal necrosis, the abdomen is closed without revascularization. How do you perform an SM embolectomy? So again, lift the transverse mesocolon anteriorly and root of small bowel exposed. The retroperitoneum is entered. The section is carried deeper, preferably towards the pulsation of the aorta. SMA may not be pulsatile if it's occluded. A 4 centimeter segment of the SMA is dissected free and controlled with the silastic vessel loop. Another buzzword: silastic vessel loop, proximal and distal. Transverse arteriotomy is performed and a size 3-4 Garty embolectomy catheter is done. So once a clean pass to receive clot from the distal MA. So first do distal SMA. Once a clean pass, backbleeding achieved with no further retrieval of clots attended, the vessel is flushed with the hypertonic saline. The process is repeated and then backflow is done in the aorta. How do you assess the adequacy of intestinal perfusion at your resected margins after embolectomy? So again, they will reduce the intestine, put the intestine back into the peritoneal cavity and irrigate with warm saline to mitigate cold exposure associated with vasoconstriction. This is again buzzwords: reduce the intestine into the peritoneal cavity, then clinical color, peristalsis, marginal artery perfusion, and bleeding from the cut end, and then physiological handheld Doppler can be used on antimesenteric border of the intestines, and then sodium fluorescein 1 gram intravenously and inspection under ultraviolet lamp for fluorescence, and then temporary abdominal closure and second loop laparotomy in 24 hours. When would you consider non-surgical treatment? How would you manage it? So if patient is not peritonitic and non-occlusive causes no finding on the CT scan, that warrants surgical intervention. So patient should be monitored in the SHDU, nil by mouth, IV hydration, and serial abdominal examination and blood laboratory testing. Underlying condition should be treated and cardiac output optimized. Sometimes people give papaverine infusion and phosphodiesterone inhibitor to increase the mesenteric flow. Intra-arterial thrombolysis is an option, and then the development of peritoneal signs indicates failure of conservative treatment and patient needs laparotomy. You have resected 100 centimeter of ileum and managed to retrieve clot from the distal SMA. The resected end of the ileum still appear pale and you are unable to establish inflow from the proximal SMA despite multiple passes of the embolectomy catheter as it keeps reclotting. What will you do? So call for a vascular surgeon. Mesenteric angiogram is indicated. If it's in the hybrid theater, do it, and then the SMA stenting can be performed by a brachial or the femoral approach. If no imaging available, the SMA should be repaired and the abdomen should be temporarily closed in order for the patient to be transferred to a vascular hybrid operating room or angiography suite for diagnostic and therapeutic maneuvers. Temporary closure of the abdomen with relocal laparotomy. So they do residual thrombus can be extracted with image and guide wire assisted thrombectomy. Stenosis and dissection flaps can be treated with an endovascular stent. Once successful revascularization done, close the abdomen, ITU, and then review relocal laparotomy after 24 hours. There is no imaging capability such as angiogram at your institution. What would you do if you cannot establish inflow to the SMA? So there are 2 points. You can do revascularization by doing a bypass, aorto mesenteric artery bypass with the great saphenous vein graft, or you can do a retrograde left common iliac to the SMA bypass to revascularize the bowel. Thank you.